You're listening to Soundside. I'm Libby Dankman. Ketamine. It's a drug you see doctors on hospital drama The Pitt give patients in the ER for pain relief or sedation. It's also what cast members on the reality show The Secret Lives of Mormon Wives take to connect with their spouses, and what some Americans use to treat their depression. Ketamine has gotten negative press in the past few years, like in 2023 when Friends co-star Matthew Perry died from the acute effects of ketamine. So we want to learn more about this substance that's showing up more and more in popular culture and in Seattle, which is home to several ketamine clinics. This is part of our recurring Ask a Doctor segment, where we ask medical professionals to help us understand health news and trends. Today with me is Dr. Nathan Sackett, an assistant professor in the University of Washington School of Medicine. He's also an addiction psychiatrist. Dr. Sackett, thanks very much for being on Soundside today.
My pleasure. Thanks for having me.
So you lead the Center for Novel Therapeutics in Addiction Psychiatry at the University of Washington. How much does ketamine come up in your work?
Yeah, that's a great question. I would say that ketamine is it's sort of in a unique position in that it's capitalizing off of a lot of the enthusiasm around psychedelics and sort of other novel compounds. And one could make the argument that ketamine is sort of riding the coattails of other psychedelics into popular culture. And I think that has both potentially good and potentially concerning effects. And that some of those questions are that we have at the Center for Novel Therapeutics is sort of, what are the long-term effects of these compounds? How safe are they? So that's some of the work that we toy with.
I mentioned up top some of the various uses that listeners may be familiar with. But before we get too far, at its most basic, what is ketamine?
Yeah, that's a great question. So ketamine is a anesthetic drug. It's in the class of drugs called an NMDA antagonist, which is a fancy pharmacological way of saying that it acts on a receptor in the brain and sort of acts as a relay station, these NMDA receptors. And ketamine alters some of the pathways in the brain. And it was originally FDA approved in 1970 for anesthesia. And it's a unique compound in that, unlike other anesthetic agents or anesthetic induction agents, it doesn't generally put people into respiratory depression. And so it's fairly safe in low resource environments. So it's often used on the battlefield or for traumas because it doesn't make people unlike opiates, it doesn't make people's breathing go down to a dangerous level. So in that regard, it's a pretty powerful and amazing compound. Over the last couple of decades, there's been a resurgence of interest in using ketamine at lower doses for things like depression or substance use. And as a result, there's been, I would say over the last decade or so, a growing interest in sort of ketamine clinics in the community for treating depression and for PTSD, as well as different services that are sending ketamine to people's homes in the form of lozenges. And I'll say it feels a little bit like the Wild West in terms of there's a lot of interest in these compounds. And for good reason. A lot of our current treatments, fail a lot of people. And so I think it makes sense to me why there would be an interest in this compound. On the flip side, I think there's been some concern around potential negative effects that we're still trying to better understand and quantify before too much potential harm is caused.
I mentioned that you're in the addiction medicine space. How does it show up there?
Yeah, I want to preface this by saying I'm not, I have a biased view in that I see people who are struggling with overuse of these compounds. So I think that's an important thing to note. But in my clinic, I'm certainly seeing more and more folks who are developing use disorders with ketamine. And I would say since COVID in particular, there seems to be, and this is just anecdotal, just from my personal experience, I'm seeing increasing cases of people who started out trying to use it for therapeutic purposes and perhaps develop a pattern of use that has led to some harms. And so I'm certainly seeing it on the rise clinically. And if you look at the research, that trend seems to be pretty widespread. We're seeing more and more potential problematic use.
So we've talked about the ways that it started out as an anesthesia, and it's still a very effective and widely used anesthesia. I know a lot of listeners will have associations with ketamine as, frankly, a party drug and something that you hear about, Silicon Valley billionaires abusing, in their everyday lives. We've talked about the ways that it has shown up in the addiction space. But psychiatry does seem to be something that's relatively new and is being, explored with more and more potential promise. Can you talk to me a little bit more about the ways that ketamine may be a solution for some people when it comes to
Yeah,
depression?
absolutely. I think that's an important point to make because I do think ketamine, like any pharmacologic agent that is potent, it has real potential as well as potential risks. And so from a depression standpoint, what I think is remarkable about it is its effect. Is its speed of effect. A lot of times we give people meds for depression, it can take weeks or months to really take effect. With ketamine, what's somewhat unique is that people will often have benefit from a mood perspective within hours to days. And so that I think is an important piece of data that should be used, particularly for folks who are, say, acutely suicidal or going into the hospital. I do think there's a real powerful role where it can be helpful in that sort of setting. On the flip side, the challenge that we see with it is that the effect is rather rapid, but it doesn't always sustain for very long, and so that can lead to some escalating use potentially to try to maintain its effect on depression. And not for everyone, obviously. For most people, it can, or for a lot of people, I should say, it can be very, very helpful. But we don't have a really good sense of the best dosing paradigm for ketamine. Most ketamine clinics will give IV infusions. They'll do it a couple times a week, and then they'll sort of space it out. And again, for the people it's helpful for, it can be life-changing. But it's still a little unclear sort of what's the best format. Does it need to be paired with therapy? Does it not? And there's a lot of debate and a lot of unknowns around those sorts of questions.
How are people accessing ketamine? We talked about the ketamine clinics. You talked about even these like mail order lozenges, and again, a Wild West situation for the way that ketamine's being distributed. But all of that's off label, right? Like the only on label use is for the anesthesia. So what is the legality around this? Like, how are people getting ketamine, or is it illegal?
So that's a great question. So I guess it's important to clarify there is a form of ketamine, S-ketamine, also the brand name Spravato, is available that's FDA approved for depression. And so that's a prescription medication, and that's formulated and FDA approved and so forth.
That's S-ketamine. Mm-hmm.
Yes, exactly. So that's sort of just to highlight that does exist and is FDA approved and has evidence for treatment-resistant depression. But that's sort of putting that aside. For people who are using, the racemic form of ketamine, there are a lot of prescribers out there who are using it. Like you mentioned earlier, pain docs. It's quite helpful for sort of chronic or acute pain. So people will often get it formulated, and you can take it intranasally or orally. So there are, I would say, an expanding number of physicians who are prescribing it. It's off-label, so insurance companies won't always pay for it, and so patients are often stuck with the bill, which causes some real challenges for folks. And that same is true for the IV infusions. Because it's not FDA approved, most insurance companies will not pay for it. And so then the patients are sort of stuck holding the bill, which, can be pricey. And I would say that's a big barrier for a lot of folks. You mentioned, illicit use. Certainly there are a lot of folks out there who are using illicit ketamine. It's harder for me to speak to sort of their motivations because it's not something that I see. It's not as common as in my clinic as people who are coming to see or to use ketamine for sort of medical purposes. So it's hard for me to speak to that specifically.
And you mentioned this already, but there are addictive properties that we're talking about here when it comes to using ketamine. Yeah.
Yeah, yeah, yeah. It's certainly rewarding. I mean, I think it's important for listeners to know that addiction exists on a spectrum, and compounds have addiction potential that is multifactorial, right? It's not like something is or is not addictive totally. There is a whole spectrum, and with ketamine, it is certainly like reinforcing. But when compared to other compounds, perhaps not as reinforcing as, say, cocaine, but much more reinforcing than more benign compounds. And I think that's where some concern does lie.
What would you tell somebody who maybe has struggled with depression in the past and traditional psychiatry and pharmaceuticals have maybe not gotten them to a place where, they feel healthy, they feel like they can, enjoy their lives, and they're looking for something different? And maybe they hear something about ketamine or they hear something about these other substances. I mean, who is a good candidate for exploring something like this?
Yeah, it's really, really hard to know. I mean, this is true of all psychiatric interventions. It's really hard for us to sort of predict who's going to respond and why. I think that, yeah, we need a lot more data to sort of pick up on that. I would say that my own clinical experience has informed me that the people that I see who respond well to ketamine in particular are folks who describe a high degree of sort of like internal ruminating, sort of negativistic, very self-critical thinking that's very harsh. And the way that I conceptualize it, and again, this is just my opinion, is that for a lot of folks who struggle with depression for a really long time, the narrative, that sort of negativistic narrative, becomes louder and louder over time and reinforced based on struggles in one's life. And where I think ketamine could be helpful for some of those folks is it reminds them that they have the capacity to actually turn down that volume a little bit of that sort of negative story. And that moment, I think, is really powerful. And if you pair that with something like psychotherapy or some longer term care, can really catalyze people into making changes. But in real time, our ability to predict that outcome is very, very limited. Yeah.
Do you think it's going to get better when we have more research on this? Like, are we going to learn more about, who responds best to these different types of treatments and what they can actually do and what they're actually doing in the brain? Like, what are you looking forward to when it comes to research frontiers in this space?
I think what doing work in this area has really highlighted to me is one of the areas of psychiatry that I hope we see change in the coming years is we need to have more specificity around our diagnoses. We call depression a disease or disorder, but it's likely a symptom of probably 50 to 100 other disorders. And so I think when we look at sort of outcomes of treatment for depression, well, of course, they're going to be poor when you're not really diagnosing things, I think, in the best necessarily in the best way. And so I hope that we get more precise with diagnoses and that culturally people begin to understand that mood symptoms by themselves is not depression, and that these are behavioral syndromes that sort of evolve over time. I think that psychiatry has done itself a little bit of a disservice by trying to equate us to sort of primary care providers. Like, oh, you have an ailment, you come to me, you've been waiting to see me for 3 months because we have a long line, and now you want a pill to fix your disorder. The reality is, and this is going to probably be controversial, but most of our disorders are complex and multifactorial and chronic, and there is no treatment that I'm going to give you that's going to fix anything, honestly. It may alleviate a little bit of the intensity, and it may alleviate or give you a little bit of hope or a little bit of a change in perspective, but change is slow and incremental. And so I hope in the coming years that psychiatry is able to sort of alter the way we categorize these disorders, because they're very real and they're very debilitating, and I see a lot of people struggle. And I don't think it does anyone a service to sort of give people false sense of what relief is. Yeah, I think these are complicated disorders, and I think the solutions, unfortunately, are going to probably be complicated.
They're complicated, and each person is so different, and
Yeah.
it requires work and care and time and everything. Doctor, I really appreciated your perspective on this and willingness to, talk about these really complex topics with openness. And I think you've, helped me understand a little bit more where we're at. So Dr. Nathan Sackett, assistant professor in the University of Washington School of Medicine, addiction psychiatrist, thank you so much for being here. I really appreciate the conversation.
Thank you so much.
Thanks for listening to Soundside. Don't forget you can listen live on KUOW 94.9 Seattle at noon and 8 p.m. Monday through Thursday, or anytime right here online at KUOW.org, or of course on your favorite podcast app.